Our next presentation is entitled Cryopreserved Arterial Allografts versus Rifampin-Soaked Dacron for the treatment of infected aortic and iliac aneurysms, being presented by Armin Tabai with the group from Mayo, and senior author is Randall DiMartino.
Thank you to the program committee for the opportunity to present our work. My name is Armin Tabai. I'm a medical student at the Karolinska Institute and research trainee at the Mayo Clinic in Rochester. We have no relevant financial disclosures. Primary infected aortic and iliac aneurysms are life-threatening and challenging to treat, with high early morbidity and mortality. Over the last decades, the treatment paradigm has shifted from extraanatomic reconstruction to in situ repair. However, there is no consensus on optimal conduit. Proposed options include cryopreserved arterial allografts, Rifampin-Soaked Dacron, and creation of a neo-aortoiliac system. The aim of this study was to compare the rates of reinfection, graft-related reintervention, and long-term survival in patients with primary infected aortoiliac aneurysms undergoing in situ repair with CAA and RSD. This is a retrospective cohort study that included all patients with infected aortoiliac aneurysms treated with either CAA or RSD between January 2002 and August of 2022. Patients with infected aortic aneurysms of the descending thoracic and abdominal aortic and iliac arteries were included. Patients with infected grafts and endovascular stent grafts were excluded, and time to event outcomes were assessed using Kaplan-Meier curves and log rank test. The diagnostic criteria for primary infection were typical imaging evidence, including perianeurysmal gas accumulation, fat stranding, or positive nuclear medicine imaging. Intraoperative findings of frank pus, intraabdominal abscess, or fistulous connections to the bowels. Clinical presentation with fever, sepsis, and a rapidly enlarging aneurysm. Furthermore, cultures and pathological reports obtained intraoperatively also guided diagnosis. During the study period, a shift was observed in conduit use for in situ reconstruction from RSD to CAA. Nearly all of the RSD cases were performed up to 2012. Following this, there was a shift almost entirely to CAA after 2012. We identified a total of 30 patients, 17 receiving CAA and 13 RSD. Although not significant, we observed that patients in the RSD group were older on average. There was also a trend towards higher rates of hypertension and coronary artery disease for RSD. However, this difference was not significant. Preoperative blood cultures were positive in approximately 50% of patients in both groups, while there was a trend towards higher rates of preoperative antibiotic management, defined as more than 48 hours of antibiotic treatment in the CAA group. The most common location in the CAA group for the infected aneurysm was the paravisceral aorta, followed by the infrarenal aorta. In the RSD group, the infrarenal aorta was most commonly involved. Due to the differences observed in infected aneurysm location, we also observed differences in the proximal cross-clamp site. In the CAA group, the proximal cross-clamp was most often placed on the supraceliac aorta, followed by the descending thoracic aorta. In the RSD group, the proximal cross-clamp was most often placed on the infrarenal aorta, followed by the suprarenal aorta. Omental wrapping of the aortic graft was performed as an adjunct procedure in 59% of patients in the CAA group and 85% of patients in the RSD group. This remains a practice standard at our institution and is performed when feasible. Visceral and or renal debranching was performed when necessary to preserve perfusion to the bowels and kidneys, respectively. 32 bypasses were created in 10 patients in the CAA group, compared to 8 bypasses that were necessary in 3 patients of the RSD group. Approximately half of the cases were culture negative in both groups. In the CAA group, MSSA was the most common bacteria identified, while Streptococcus species was the most common in the RSD group. Highly virulent microorganisms were less frequently grown on tissue cultures. Of the 8 culture negative cases in the CAA group, 6 patients received preoperative antibiotics, and the other 2 had positive bacteremia preoperatively. Of the 7 culture negative cases in the RSD group, 3 patients received preoperative antibiotics, while the other 3 had positive preoperative bacteremia. In-hospital mortality was similar, with 3 deaths in each group. while any complication occurred in almost half of the patients in both groups. In the CAA group, 2 deaths occurred due to multi-organ failure, and 1 death occurred due to graft rupture on post-operative day 4. In the RST group, all deaths occurred due to multi-system organ failure. Median follow-up was 13 months in the CAA group compared to 15 months in the RST group, and no late deaths occurred due to graft-related events. Survival at 5 years was 64.8% in the CAA group and 57.7% in the RST group. 4 patients in the CAA group underwent graft-related reintervention compared to none in the RST group. Indications included graft stenosis, 1 in a renal bypass graft, and 1 other as iliac anastomosis, both of which required endovascular stenting, graft rupture in 1 patient, and graft reinfection in 1. Freedom from reintervention at 5 years was 39.8% in the CAA group and 100% in the RST group. One patient in the CAA group was diagnosed with reinfection and required graft explantation and a new reconstruction with RST. Freedom from reinfection at 5 years was 90.9% in the CAA group and 100% in the RST group. While this is a small retrospective cohort study making robust comparisons limited, our conclusions are that there were similar outcomes in both groups, while there was a trend towards higher intervention rates in patients with infected aortoiliac aneurysms undergoing in situ reconstruction with cryopreserved arterial allograft. We feel that both remain options for in situ reconstruction. However, patients undergoing in situ repair with cryopreserved arterial allografts may require short follow-up for early detection of graft-related complications. Thank you.
Okay, you want to go first?
Sure. Andrew Kimball from Michigan State University. Very interesting talk. I'm curious if you have started to be selective with which conduit you use in the setting of which bacteria the patient's infected with. Just anecdotally with our group, we've noted a lot of, with gram-negative organisms, we've had multiple patients blow out cryografts, and so we've kind of shied away from that, and we're using more Rifampin-Soaked Dacron for those patients, but we've been very successful with gram-positive organisms with cryo allografts. So just curious about your experience with that.
Yes. So generally, the presumption is that cryopreserved allografts have a higher resistance to reinfection. So for highly virulent microorganisms, we generally prefer to do cryograft, while if the bacteria is not highly virulent, we can sometimes go with RST if possible. So yes.
Armin, that was beautiful. You're a medical student, yes?
Yes.
Yeah, bravo to you. That was a lovely presentation and exactly what we'd expect from your team's work. So congratulations on a nice presentation, and I just have a big picture question for you that you may be able to answer, or I would defer to your mentor. 30 native infections over the course of 20 years is actually not insignificant, and I think that the risk factors and demographics that you highlighted show that oftentimes you go into these operations and you don't have all the information you really want to have to make a decision. So based on your findings, as you're approaching these patients, I think when you know what the infecting organism is, it might help delineate an algorithmic plan towards what conduit you choose. But how are you managing these patients? Are there other risk factors or associated comorbidities or findings that influence what conduit you select? And then the other question might be a little trickier, but that really is, how do you propose others take your data, acknowledging different practice patterns across the country when we think about real-world implementation of things? That's a bigger question, but I do think that the Mayo series are always a bit unique when we consider practice patterns at that institution in comparison perhaps to other sites. Thank you, and well done.
Thank you. So generally for high-risk patients that are deemed inappropriate for open repair, the last years we have in some patients done an EVAR. Generally we do not prefer doing it in patients that are appropriate risk for open repair since we want to get rid of the infection. So that's when we can go with the endovascular option. But generally, when we consider open repair, cryo is the preferred conduit, and during the last decade, it has been that at Mayo. And the other question, maybe Dr. Martino can.
Randy, just hold on one second. Let's get through the other questions real quick, and then we have you address all of them at once. Is that okay? Sure. All right, great. Good, Greg.
Excellent job. Did you include or exclude patients with enteric fistulas? And then second question is, you mentioned that you thought cryopreserved allografts potentially more resistant to infection, but actually you showed that the only infection was in that arm. And now that you're mostly doing cryo and not rifampin-soaked, do you think you're going back, or how do you choose?
So for the aortoenteric fistulas, we had one patient that had a primary aortoenteric fistula that we included. And for your second question, our historical data showed that cryografts have a lower reinfection rate compared to rifampin-soaked Dacron, but we are considering this data that we presented today in choosing the correct graft, the best graft for the patient in the future.
Great presentation, John Eliason from Michigan. Just had two questions. One is, what makes an institution change the way they do things? You had that 2011 paper that had such good data that guided a lot of people's kind of adoption of that technique for infected aortic grafts. A little bit different, but somewhat similar. And so then you shifted completely away from that. So one is, what made that change? And the second question is just cost. Have you looked at cost and what the allografts cost and extra branches and all that, and then total that out and see, is this a financially good move for hospitals to do?
Thank you. So the shift that occurred in 2012 was mostly because of the historical data that we presented back then by the division that showed that cryografts had a lower reintervention and reinfection rate compared to RST for infected grafts. So that's why we changed to cryo for primary infections and secondary. And for your second question, we have not looked at cost, but there are other studies that have looked at that, and they have shown that cryograft generally costs more than rifampin-soaked Dacron because of the cryopreservation process, and that you need special refrigerators at the hospitals where you store these. So we did not look at that specifically, but previous studies have shown that cryo costs more than rifampin-soaked Dacron.
All right, Dr. Rajani Suarez has a very, very quick question.
Super quick question. Great job. Dr. Coleman's point, 30 cases in 20 years, if I remember correctly, but it's really a super select group potentially. You excluded NASE procedures, you excluded people who were having endografts. Can you give us some sense of what the total volume looked like? Is this really a select group of patients, or is it indicative of many of the patients who came to Mayo during that time?
So Randy, let's just have you cover a couple of those, and then.
Yeah, the overall series was just slightly large. This is probably 70%. So most of the patients in these primary treated ones, I think it's a good point. We have had this pendulum, rifampin-soaked. We used a lot of cryo. I think the draw was try to get people off long-term, lifelong antibiotics, because after a year or so, there's really no need with the cryografts. But I don't really think we've had good long-term data, so that's the goal here. And I think it is sort of making us rethink this, because I've had a bunch of reinterventions, and so I think that it's important to try to collaborate and bring these cases together so that people can make good decisions. I think there'll be local decisions, but I think both are good options. I think that's the take-home today, at least, but just be sort of aware of what you need to look for long-term.
Okay, great job.
Thank you.